Okay, thanks. Yeah, I mean, I think that sounds good. I think for many of those patients, I mean, I could be guessing, but it's also like an example of maybe a stable, mature relationship, that between therapist and patient. So it's obviously, they probably, yeah, they obviously learn something from that from a skills point of view. Does that make sense as well?
Yeah, I think it makes sense because it's really important to teach them positive skills, which
Mm,
BPD. So with also shame focused therapy, it's also like it can also be individual based and a group, which is a bit different than dialectical behavior therapy. But it's also about to identify unmet needs that leads to negative life patterns, or maybe teaching them helpful survival strategies. So
mm,
it's like it focuses on helping their needs are met in a healthy manner and like in a more promoting positive life patterns. So like it's actually skills based, like if they feel hurt, if they feel rejected, for example, they learn to how to practice mindfulness and um other kind of skills that could help them. And then they with the shim therapy they there is like actual CPT courses on that, but mainly they learn to how their childhood shims like like learnings lead to thinking in a way which is harmful. Like it's actually like a CBT, but it's
mm,
not a CBT. So they learn to find out that negative life patterns and spotting them, and then how to make it a positive life pattern, like how to change it to be more positive. And I think without being judgmental and being there for the client, it's really good for them. Like it really feels them like they're accepted. But if they have like three or four attachment style, it's really even a bit harder to get their trust and get them into therapeutic trust. Um, so I think that's why the group therapies like DBT could be really helpful
mm.
um, for this group. And they learn how to do interpersonal effectiveness, distress tolerance, and emotional regulation with mindfulness in DBT. So it's like actually four different skills group, and
Mm.
both individually and like also like in a group they could practice it later on.
Okay. Yeah, that sounds really cool. Like we said, and then I think when we prepared as well, we said, is there like a test, or I mean, I know you mentioned DSM-5 now, which is really cool, and the five aspects. Is that how you would normally determine whether someone has personality disorder, yeah,
Mm.
or not, or
Yeah,
borderline? Sorry, no, borderline personality disorder.
yeah, actually there is like a test for scoring the BPD level, like it's the MSI BPD test. But also like in the UK we tend to do like if the GP, for example, suspects any depression or instability, they first find out if it's depression or not, and if not, then they refer them to the clients to the community mental health teams, which are more like specialists in that area in personality disorders. So there is actually like small sheet which has like questions. So if they say yes to five of them that questions, then they do usually have BPD. So they have like questions like, do you have a long term of emptiness or loneliness feelings? Or do you have a pattern of intense and unstable relationships? Or if you ever have feel you don't not have a strong sense of yourself and unclear self-image, or if they engage on drug misuse, reckless spending, or self-harming, or mood swings. So and there is like this McLean screening instrument test with like the MSI, which I mentioned.
Mm.
It's also like a 10-item measurement, which is like more, I think, more US and more technical one. So it's like if they say get a score from like from 0 to 10, if they get 7, it's generally an indication of a criteria for BPD diagnosis. Um,
Okay.
it also has like some questions like similar, but it's more like a I think more like research-based test, whereas the other one is also research-based, but it's more like a simple, basic kind of test. But both of them are really accurate in, I think, finding out if somebody could have BPD.
I'm actually not familiar with those. So the MSI, I haven't come across that before with practitioners as well. So is that a common test for in the UK, or is it a common test throughout the world?
It's a throughout the world test, actually, like it's
Okay.
used everywhere. But I think in the UK, the first thing which you tend to use is this test, the one with like internationally recognized criteria, a test which I talked really about. So if they say 5 to any of those questions, which is actually some of them are like usually they are based on the DSM criteria. So 9 of the criteria, if you say yes to 5 of them, then they get diagnosed. So it's both of them are actually internationally recognized tests.
Yeah.
But I think one of them is a bit simpler. So it's both of them is really accurate, and probably the international recognized criteria one is simpler to use, so it's more straightforward.
Mm.
So that
Yeah.
tends to be used more in this community mental health team. As I'm also like having a placement in community mental health team right now as a part of my doctorate course
Okay.
in
Yeah.
UK.
Yeah, that's actually really cool. I mean, I love the fact that you have that experience. I think for what I've always heard, especially from healthcare practitioners in South Africa, where we originated, was it's normally the DSM-5, and then obviously they're looking at the criteria there. But I haven't heard anyone mention that particular test. Maybe they do it. Maybe I haven't asked the question in a much more pointed fashion. But you mentioned something else though, Rosie. The DP. Who is that? So
Oh, sorry, which one?
the
Uh,
DP. So normally the DP does the diagnosis, or the
sorry, I meant GP, sorry, like general practitioner.
okay, GP. Okay, sorry, my bad. Yeah,
Yeah.
so GP would normally just okay, so start the process. That makes sense. I think
Yeah, they use
that's kind
for
of common.
community health team usually in the
Okay.
UK. They suspect
Mm,
it.
okay, that makes a
Yes.
lot of sense.
Yeah.
And typical treatment for borderline personality disorder. So assuming that, they obviously went through the initial screening process, the assessment came back.
Mm.
Um, what happens from there?
Uh, Treated with psychotherapy, like such as like cognitive behavior or dialectical behavior therapy, and sometimes medication is used, like if it cannot be really cured and it's really severe, like quetiapine or SSRIs, like antidepressants, are widely used in that case, because then they are actually good for mood stabilization. Because quetiapine is actually like antipsychotic, but it can also use for major depressive disorders or bipolar, which is kind of similar as in the outset of like, because bipolar is actually more like based on the brain functions, but it's actually very similar with BPD, some of the symptoms, like so it's a similar medication, and sometimes you like very severe cases needs hospital care, um, but it's like less common, and therapy of BPD for BPD can occur in one-to-one and also in a group setting. And DBT really, based on the empirical research, DBT is found the most effective type of therapy for BPD, like borderline personality disorder, and it may reduce the risk of suicide in this disorder. So this is like the therapy which is actually the best fit based on the research for DBT.
Okay, cool. I mean, I think that makes a lot of sense. I mean, and I suppose, the therapy aspects, we covered. You did get my interest going with the with what you said earlier, though. It seems to get better with age. And is there a reason for that, or is it just that people start learning coping skills and they get better with relationships? I'm kind of guessing or coming from that angle, but is there a reason why it gets better?
There is like I think it's like 2 research articles that published that say it gets better with age around also 25, like it's getting better and better. And also I think one of the reasons they say with 25 actually the part of our, like one of the areas in our brain changes, so like emotional regulation becomes to be like it becomes to be better processed. So they say suspect one of the reasons could be that. And also I think with aging, one of the papers were suggesting that we kind of learn how to be attached more securely, and with like getting skills more like using them efficiently. And if they get therapy, then it gets better. And with, I think, adolescents, the research was saying it gets even worse because some of the criteria is actually like not that severe, but experienced in adolescence by all of us to a little bit, not that big of an extent, but just at least a little bit. So if they have BPD, it's really tops up with that adolescence period. And then it's really, the research shows it's really is very intense in adolescence, but it settles after 25 and maybe gets better with age. Like that was what the research said. Yeah.
Yeah.
And then one research was saying actually it needs to be researched further, the reasons. So that was why I wanted to do another research about this for my PhD, in like as a second research actually, because I'm currently doing a research about BPD and DBT.
Okay, that's nice. Yeah.
Genders.
I suppose that's even more the reason why the diagnosis at an early age is difficult or problematic, because I mean it is, as you said, with adolescents, they already, I mean, it's already going to be heightened, and it's, yeah, so I can kind of see the problems with that. And in terms of the, I mean, we covered the typical treatment. I think we covered symptoms. We covered, the diagnosis, I suppose, as a teenager. But I mean, I would be correct in saying, I mean, I don't think you would ever get a diagnosis before that time.
Yeah, like we were during the placement and our training, like we are told to really try and avoid diagnosing before 18. But in severe cases, it could be diagnosed as emerging BPD. But according to the DSM, which is a US based manual for psychological disorders, it's actually diagnosable before 18. So but they avoid to not like do that as practitioners, and more likely to wait and see how it gets, because it also creates a label in the person. So
Yeah, I know.
according to
And that's
the
always difficult. Yeah.
perspective.
Yeah. Can I ask about the medicines? And I know obviously psychologists can't prescribe them or anything like that, but in the UK, like antidepressants and things like that, do you find that that's, I mean, are there cases where people take antidepressants for quite some time? And is that normally recommended then by the GP or the psychiatrist? Hey everyone, thanks for listening. As always, stay tuned and we'll speak to you in the next episode.